Thank you all for having me here and for the nice introduction, Mr. Zapata. Uh, so I, I, as Mr. Zapata already introduced me, I'm Dr. Boddapati. I am the assistant professor at UT Health San Antonio and work in the child division. I have a special interest in developmental disabilities, which is why I work a lot with the uh, lot at the dual diagnosis clinic for the Center for Healthcare Services, which is located within the Morgan's MAC or the Morgan's Multi-Assistant Center. Uh, or can I share? Okay. Are you all able to see my screen?
Yes, sir. We can see it. Thank you.
Okay, perfect. So today I'll be talking about the different medication and behavioral interventions in autism. Uh, I have no conflict of interest for the presentation. And the objectives for today's learning are first, let us see some of the core features of autism and the common psychiatric comorbidities and the medical comorbidities associated with ASD. Um, and the reason for this, I know this is part of the series, and I won't go too much into the features and but I want to understand you to understand the comorbidities because that is what we intervene when we intervene with behaviors or with medications. That's what we are trying to intervene. And then also to look at the evidence for the treatment of different symptoms, the behavioral interventions, and then also the medication treatment. I wanted to put this slide to emphasize that each individual with autism is unique. Each individual has their own strengths and deficits and challenges. So, but everybody is again different. So if we have met one person with autism, we have met only one person with autism. The same holds true for the treatment modalities too. So there is not like a one girl fits all hands kind of approach. We need to individualize and customize the treatment for each individual based on their strengths and deficits. So starting off, if you look at the core symptoms of autism, we have the impaired social communication, which presents as like difficulties in social reciprocity, problems with nonverbal communication, and understanding relationships. In addition to that, we also have the restrictive and repetitive behaviors, which can present as like the rigidity, restricted interest, insistence on the same, repetitive speech and behaviors, and also the sensory abnormalities. While these are the core features or symptoms of autism, we also have a very high comorbidity with like there's the cognitive comorbidities, so it's often associated with intellectual disability or language impairment. We have the psychiatric comorbidities with anxiety or like ADHD, often presenting as like agitation, aggression, very high comorbidity with like mood disorders. Um, then when we look at the medical comorbidities, we also have a lot of neurological comorbidities like seizures, psychological non-epileptic seizures. And then we have like GI issues, which because of the sensory issues, they could have like ARFID, eating disorders, GI issues causing like severe constipation, etc. And there is a reason I explain these comorbidities, because oftentimes when we say we are treating autism spectrum or we are intervening in autism spectrum disorders, particularly with like medications, these are the comorbidities we are trying to treat because we cannot really treat the core features of autism spectrum disorder with medications. With behavioral interventions, yes, we can. Another slide depicting the lifetime prevalence of some psychiatric disorders in children with autism. Again, very high comorbidity with like ADHD, Anxieties, particularly specific phobia, generalized anxiety is slightly less. And then schizophrenia, I know it shows 0%. That's because this slide only depicts the um, psychiatric disorders in children, but when we get to adults, there is also high comorbidity with like psychotic disorders and definitely mood disorders. When we say we are treating autism spectrum disorder or the different symptoms, we always have to take a holistic and a comprehensive picture. We have to take a multimodal approach, which includes, okay, I'm not just treating with just one medication or one behavior intervention. It has to be a combination of different things. Um, and the interventions also need to be not just age appropriate, but they also need to be developmental stage appropriate. What I mean by it is sometimes we have, oh, someone's 18. We cannot just because they are 18 or 24, they cannot be treated as an adult. Sometimes we have to take the developmental stage into consideration when we are using the different interventions. And starting off with the behavioral interventions in autism. Uh, so when we look at it, whenever we think about the behavioral interventions or the different therapies in autism, the first one that comes to mind is ABA therapy. We say ABA therapy, applied behavior analysis. And the reason for that is it's because the most research-based, strong evidence-based approach. But there are other interventions, other behavioral therapies and interventions that we can utilize. And historically, ABA used to be the mainstay of treatment, but more recently, with evolving therapies, ABA is complemented with the different therapy modalities. And the best outcomes are when the interventions are started early and when it's combined and individualized for different uh, individuals with autism. So as you can see from the slide, ABA, NDBI, and parent-mediated therapies, functional communication therapy, they have the strongest evidence. We'll look at each of these individually. The adapted CBT, somewhat moderate efficacy or moderate evidence. Teach and PECs, they also have moderate social skills programs. Although the evidence is weak, I think if you take a subsection of individuals who are autism spectrum disorder or the high functioning or what we call the level 1 autism spectrum disorder or the adolescents with good language capabilities, they seem to have a better response for better outcomes with the social skills programs. Now, let's look at each one of these a little bit more in a little bit more detail. The big one is the applied behavioral analysis. This behavior intervention or therapy has been the most extensively studied for autism spectrum disorder. Now, the big advantage with ABA is that this can be effective across all intellectual and language abilities, right? It can be applied for nonverbal people, highly verbal people, irrespective of their cognitive ability. The ABA can be applied. Now, the basic principles of ABA go back to the operant conditioning by Skinner, where, it goes back to like learning reinforcement and behavior modification. What basically happens is one looks at the antecedent, the triggers for the behavior, then change the reinforcement by using positive and negative reinforcement, change the environment and then, or the therapy, and then thereby changing the behaviors. Now, it is a very high intensity. As you can see from the slide, if it's a comprehensive ABA applying for like very wide range of outcomes or interventions, then it has to be like 20 to 40 hours per week to be effective. If there is only like targeting a specific behavior, then it can be like 5 to 20 hours per week, which is still kind of high. So it's very high intense therapy, right? Now, the biggest advantages are that there is ABA has shown that there is improved communication, language skills. There is a better adaptive and daily living skills. It has been shown to be effective in reducing challenging behaviors like aggression, self-injurious behaviors. ABA has also been shown to be effective for like improving school acceptance and readiness, participation in school. Now, the caregiver burnout, confidence and skill, it's a little bit of a double-edged sword. The high intensity sometimes by itself can cause caregiver burnout, but at the same time, in the long run, caregiver burnout also improves. Some of the concerns or limitations is that, again, the high intensity can be burdensome. Um, Acceptance can be variable depending on the ability beliefs of the family or the individual. Now, when they looked at it, compared to the traditional ABA, and when you compare it with like the naturalistic developmental behavioral interventions, the NDBIs, there's less improvements in the core social emotional reciprocity, the core features of autism. Although there is improved communicational language, it's more like based on learning. It doesn't really improve the uh, core features of it. It improves the behaviors associated with autism, but not really the core features. But that again, that is the traditional ABA with more and more adaptations for the ABA and the changes. When it's individualized, there are better outcomes. Some of the barriers to treatment for ABA, individual factors include if the individual or child has like medical or psychiatric comorbidities, it can um, interfere with them participating in the intense therapy. Um, Oftentimes, aggression and self-injury acutely, although it does help both aggression and self-injury, when there it's more acute, participation is impacted. Sensory sensitivities of the individual can also impact or limit the participation in ABA therapy. And when it comes to the family factors, or like usually the delay in diagnosis, not recognizing it, that's the major factor that impacts the treatment. Remember, when we do intervene, when you intervene early on with ABA, the outcomes are much better when rather than when you compare to intervening later on in later on in life with ABA. Also, transportation challenges, caregiver burnout, cultural language barriers are some of the other barriers to treatment for ABA. And when we look at the system barriers, um, I'm sure like whenever you refer a patient for like ABA therapy or like you probably hear about the long wait lists. Oftentimes, like they are about like 6 to 12 months. And that's probably because of the shortage of like people who can actually provide ABA therapy, shortage of the BCBAs or finding experienced providers. Another big barrier is the insurance authorization. Although this can be effective, pretty effective for any age range with any intellectual abilities, insurance companies arbitrarily like make rules saying that, oh, the kids above 18, ABA is not approved or so they're only approving for like 5 hours when the patient actually needs or the individual actually needs about 40 hours per week, right? And then access in rural areas is also another concern. Um, Now there are some modifications and there's more like some tele adaptations for ABA, but that's still kind of limited. Um, so these are the big barriers to treatment. But it is when done appropriately and it's individualized, this is still one of the most evidence and the most successful treatment modalities for individuals with autism. Now, going to the naturalistic developmental behavioral interventions, um, these interventions have moderate to strong evidence for improving language, social communication, adaptive functioning, and parent-child interaction. Compared to the traditional ABA, the NDBIs are more child-led and play-based. So um, there is better participation compared to ABA, you can say that. Some of the examples for this are the Early Start Denver model or the pivotal response treatment or JASPER, also called the Joint Attention Symbolic Brain and Engagement Regulation. Typically, this is effective when administered between the ages of 1 and 6. So toddler age and like the preschool age and or the early school age can be, this intervention can be effective. Then we have the parent-mediated interventions. And this, the therapists teach, train, and model, review the video recordings of the parents interacting with the children, and the trained caregivers there, trained parents or the caregivers then use the therapeutic and communication strategies during daily routines. The strategies are woven into like play, meal times, everyday household routines, and they mainly target joint attention between the child and the parent, two-way communication, and managing childhood challenging behaviors. Again, this intervention is pretty effective and applied for toddlers and preschool children. The benefits include improved parent responsiveness, better social communication, and in the long run, it actually boosts parent confidence and lowers the long-term caregiver stress. Some of the major advantages of the parent-mediated interventions include consistency, early access to care even before a formal diagnosis is finalized. So, you don't need like the formal diagnosis of autism spectrum disorder, or you don't have to wait until then to get to start these interventions. And it's pretty cost effective as well. Functional communication training. This intervention it's delivered within ABA programs, but it's also supported independently. In this intervention, an appropriate communication alternative is taught that serves the same function as the challenging behavior. This targets aggression, self-injury, property destruction, tantrums, and there is a strong evidence for reducing self-injurious behaviors and aggression with this intervention. The social skills training, as I said earlier, the evidence is weak when you look at the whole autism spectrum disorder, but when you take subsections where there are kids or individuals who have like level 1 autism or who are like school age children with better verbal skills, in those, this can be effective. Some of the examples are like the peers or the groups social skills training. Usually the social skills training has been shown to improve friendship skills, perspective taking, social confidence, conversations. Evidence is strongest when there is caregiver involvement in the social skills training. Then we have the adaptive cognitive behavioral therapy. Um, Autism adapted compared to the traditional CBT. This one utilizes more concrete language, visual supports, and also involves higher parent participation to support it. This is best for ASD individuals with certain psychiatric comorbidities like OCD, mood disorders, anxiety, and it's usually appropriate for individuals who do not have a significant intellectual ability or cognitive deficits and better language verbal skills. Then we have the positive behavior support. This intervention is frequently used in schools, group homes, and community settings. It focuses on environmental modifications for skill building, improving quality of life. This also involves preventing behaviors rather than reacting after the behaviors happen. Teach, or the treatment and education of autistic and communication handicapped children. This is commonly utilized in the educational settings like schools. It is a flexible research-based teaching strategy created in the 1916s at UNC. So where I did my training, the teach was being utilized a lot more because I trained in North Carolina. It uses predictable routines, organized physical spaces, and visual cues to match how autistic individuals naturally learn. Best evidence for improving independence, reducing anxiety, and it also supports lifelong learning. And then we have the augmentative and alternative communication. Some of the examples include the PECs, which is a picture exchange and find, where they can like show pictures instead of communicating. And also like the speech generating devices, the common apps we hear or we usually utilize, the Proloco, to go, the Tot Chat, they're all based on this modality. Usually this intervention improves functional communication. Because it improves the communication, oftentimes it reduces the frustration, challenging behaviors like aggression. And earlier on, there were some concerns that using augmentative and alternative communication might delay spoken language development, but later on studies have shown that it doesn't really delay spoken language development, so it does not. So far we have seen like the different behavioral interventions for addressing some of the core features or some of the behaviors associated in autism. Now we'll look at the medications. Um, Again, the big thing about the medications is that we don't have cure for autism. There's no like approved medications or interventions to cure autism. We only manage certain behaviors and comorbidities. Whenever we talk about um, the FDA approved medications for autism, the risperidone and the aripiprazole, we are actually saying that these are the medications that are FDA approved for treating irritability, agitation, and aggression in autism, not necessarily cure or treat autism itself. So we'll look at some of the medications that we use commonly for different symptoms of um, that we see in ASD. So the most common presentation or people when they refer to for medication management is the most common complaint is aggression, right? And we use different different classes of medications from stimulants to antipsychotic medications like risperidone or aripiprazole, or like mood stabilizers, antidepressants, beta blockers, antihistamines. We use it. Again, this is we have to choose we have to look at the medical comorbidities, the psychiatric comorbidities, what's the presenting concern, what's the context of it, and based on that, we use we use the different medications. Um, Most of the time for aggression, we do use risperidone and aripiprazole, but those are the two FDA approved medications. But sometimes we need to use like alpha agonists and stimulants if there is like associated ADHD. We'll look at them individually. So the For irritability, risperidone and aripiprazole, as we have seen, they have like randomized controlled trials where they have had positive results. Olanzapine is another one that's not FDA approved, but it still has a positive randomized controlled trial in ASD. Lurasidone, sometimes when we are concerned about the metabolic side effects of weight gain or high risk for developing diabetes or lipids, hypercholesterolemia, then we use lurasidone, also called Latuda, but it doesn't really have like a positive title. We use it off label. Some of the other off-label medications that we use are ziprasidone or Gedone and quetiapine or Seroquel. Again, this medication class has the greatest evidence base for irritability associated with autism spectrum. And then we have, as we have seen from an earlier slide, one of the most common or highly comorbid condition is ADHD and autism. Typically developing individuals or kids, we use stimulant medications like methylphenidate or like amphetamines to treat ADHD. However, when we look at the individuals who have autism spectrum disorder, the stimulant medications have somewhat lower effectiveness and higher rate of side effects compared to, youth without ADHD. And the more common side effects are irritability and agitation. It's still, there's a pretty good response, so we still use these a lot. Um, but sometimes maybe it's not the first line medication. Sometimes we use them as a second line medication, and we use like other alternatives. Uh, since stimulants, which are typically the first line in autism spectrum, we also like consider like non-stimulants like atomoxetine, which sometimes seems to be a little underutilized in this population. There's a pretty good response of about 40-45% in one trial. Um, and usually there is better tolerated compared to the stimulants, but there is also there are some side effects like decreased appetite, abdominal pain, which in turn can again increase abdominal pain, associate feature, things like that. GI issues can kind of increase aggression or agitation sometimes. But it's been shown to be like pretty effective for like inattention and hyperactivity. Another class of medications are like the alpha-2 agonists, which is clonidine, guanfacine. They seem to be pretty effective for impulsivity, hyperactivity, especially when there is comorbid anxiety and sleep problems. Uh, it can be considered, these medications can be considered as a first line medication. Common side effects include sedation, dry mouth, um, and there is like decreased appetite. Clonidine is a little bit more sedating, so oftentimes there insomnia is very highly comorbid in ASD. So clonidine is a medication that can be utilized for both ADHD as well as for like sleep. Guanfacine usually better tolerated due to less side effects compared to the clonidine. The long-acting medications, the guanfacine and clonidine are FDA approved for like ADHD. Anxiety, again, there are limited studies for individuals who have autism in regards with anxiety. Typically, SSRIs, the first line medications which are used in typically developing kids or individuals, um, they seem to be some less tolerance to these medications. When I say less tolerant, they're not as well tolerated, high likelihood for like side effects. We still use them. Um, but oftentimes, again, alpha agonists like clonidine or guanfacine can be an alternative. Buspirone is somewhat underused. It is usually better tolerated and with some limited evidence for like benefit. Even when we are using SSRIs for ASD, we also have to make sure that there are like uh, lower doses and like titrated gradually. Depression and autism spectrum disorder, again, very limited data or no data. If when we use it, we try to use the SSRIs, which have shorter half-life. That way they don't have like prolonged side effects. We use the ones like Zoloft or Celexa or citalopram, sertraline. Um, Other than SSRIs, bupropion and mirtazapine can be utilized. If it's only seasonal depression, light 10B can be effective. Omega-3s have been shown to be somewhat effective. Again, limited evidence, but some people respond to those. Lamotrigine, the mood stabilizer that can also be used as an adjunct for depression and autism spectrum disorder. Repetitive behavior. Sometimes this is um, it's kind of hard to differentiate between OCD and the repetitive behaviors associated with autism. And there is a high comorbidity between OCD and autism spectrum disorder as well. Uh, Most of the trials using SSRIs have limited data and they're like negative. Usually therapy is still the main modality of intervention, CBT and ABT. Um, just like in anxiety, again, if we have to consider SSRIs, shorter half-life, SSRIs are better. Sometimes if this is associated with aggression or self-injurious behavior, to a point of concern, then we might use atypical antipsychotics, which seem to be effective. There are these are some of the interventions with like very one trial or a couple of trials with which have shown to be effective, but the evidence is still weak. Among these, I would say the picks my omega-3s. They have shown to be somewhat effective with vitamin D. Cannabidiol. This is a frequently encountered question from the parents. Can I give my kid cannabidiol or cannabis CBD? Um, there's only one trial which was shown to be like effective in improving social communication and behavior. Again, I would say the evidence is still kind of limited. I think we need to wait for more trials and more evidence before we say yes or no. Mirtazapine, um, it was it was used for effective for like anxiety. Um, it had some clinical response, like although it was not statistically significant, the clinical difference was meaningful. And then going to some of the general principles when we are using medications. I know we looked at the different medications. I think before we even intervene with medications, first we need to see, especially if this is a chronic behavior that's associated with autism, okay, is to regulate mood, we can sometimes use antipsychotics and all. But if there is like an acute change in behavior, oftentimes we have to rule out, make sure we are not um overlooking some pain, especially in the nonverbal patients. Oftentimes, pain can present as like aggression, pain, or like constipation. Um, some other medical comorbidities, they can present as aggression. So we actually need to like have a look at those and intervene before we jump to using like some of these medications which are used on a long-term basis. Also making sure and using whenever we're using the medications, we need to make sure we are tracking the behaviors uh, and seeing is has there been an improvement from in these behaviors, or is there like worsening, especially with some of the antipsychotic medications, although they are indicated for um, aggression, sometimes they can cause worsening of aggression because it can cause side effects like akathisia, which patient doesn't understand or the individual doesn't understand or they cannot express themselves, and they can make it worse. So if that's the case, then that's why we need to like make sure we are tracking and adjusting medications based on that. Typically, if there is like a complete symptom resolution, we should always try to reevaluate the patient and see if we can minimize the medications, considering that there are like some long-term side effects with these medications. In general, guidelines always start low, go slow with medications because individuals with autism seem to be particularly sensitive to side effects. And always warn or educate the parents that the response may be unpredictable. Um, just because even if a medication work with for someone in the family doesn't necessarily mean it would be effective for everybody in the family. Sometimes we have to they could have like an paradoxical reaction to the medication. So I always warn them to watch for like any side effects. And whenever it's possible, make sure like we are changing one thing at a time to kind of see no quick medication changes or drastic medication changes. And always like it's always better to like collaborate with like everybody on the team treating the patient to make sure we're not missing anything else, whether it's the medical provider, the therapist, the behavioral BCBAs, or the psychiatrist, the school teachers, the parents, everybody. The take-home points would be again one, the goals and the treatments should be individualized, functional, and family-centered. There's no one treatment fits all size. Um, Even within the behavioral interventions, it has shifted from like ABA being the main modality to like taking a little bit more holistic approach and either utilizing other interventions along with ABA or complementing to complement or supplement ABA, and taking the developmental level into perspective. And big thing, if someone's asking you, parents are asking us, there is no medication to cure autism spectrum disorder. We only manage symptoms and the comorbidities associated with this ASD. All right, I think all right. Time for questions.
Great. Thank you, Dr. Boddapati, for an excellent presentation. We appreciate you sharing your expertise and medical insights on behavioral and medication interventions for autism, and for helping us better understand individualized, family-centered approaches to care. Now is the time for questions. If anybody has any questions or comments for our presenter for today, feel free to unmute yourself or to type them in the chat box, and we'll be more than happy to read them out for you.
I'm sorry, I just saw the message around that was about 10 minutes ago saying that they had a hard time hearing. I'm not sure if it was anything on my end.
No, you were coming in clear for us on the hub team, and I think for the majority of the attendees.
Oh,
Do you have any questions, anybody? Okay, we have a question from Rosalva. She asks, can a child with autism take Tylenol?
yes, I know there has been a lot of debate around this topic recently. Um, As of now, there is no strong evidence to suggest that Tylenol causes any worsening of symptoms with autism. If it is indicated, if there is an indication to take Tylenol, I would definitely encourage them to consider taking Tylenol. Of course, it all depends, you'd have to discuss it with the medical provider if it's indicated. It should be taken. There is no contraindication at this time for anyone with autism to take Tylenol.
Great, thank you. The next question is from Maria Benya. I think she's saying, are there any options when the family does not want to take medications? Any kind of non-pharmacological options that are available?
Yes. So our first intervention, our first recommendations are always like behavioral interventions. We use, of course, to treat the psychiatric comorbidities, we always have to weigh the risks and benefits and offer medications if needed. The different behavioral interventions we discuss, they are our first line recommendations most of the time. Now, if you're asking about more like alternative treatments, we, you know, we can like recommend omega-3 fatty acids. That's the one which has shown to be like somewhat effective. Another common one that I usually get is leucovorin, especially with the recent debate about leucovorin being utilized for autism. It is only in a very specific subset of people, individuals who have autism. There is a condition which I'm blanking on it right now, uh, where there is the antibodies against the folic acid receptors, and that's where in that very subset of population, again, this is a very rare condition, um, that's where leucovorin has been shown to be effective.
Thank you.
And then someone asked, cannabidiol improved social communication and behavior according to the study. Again, it is a one trial. It is very limited evidence, small trial. I don't know if it was like randomized double control trial either. Uh, and the doses are not, I am not familiar with the doses for the cannabidiol.
Understood. Thank you, doctor. We also have another question. Maruf, correct me if I'm wrong, but you're asking, what omega-3s do you recommend for a 25-year-old adult?
The what dose of omega-3 fatty acids? Or is that the question?
Uh,
I'm sorry.
I believe that's the question, yes.
Yeah, the one that's common, anything that's available in the commonly available in the market, I would recommend that. Again, the evidence is iffy, but if there anything that's available in the market.
Awesome. Okay, and I think the last question is if you would mind providing your contact information in case any of our attendees have any follow-up questions.
Sure, I can. Do you want me to put my email in the chat? Would that be
Yeah,
helpful
that'd be
or?
great. Yeah, that'd be helpful. Thank you.
Okay.
Awesome. So Dr. Boddapati, on behalf of our team, just thank you so much for sharing your time and your expertise. Your presentation was very practical and evidence-based, and we greatly appreciate your time and your contributions in this field. Thank you so much for an excellent presentation.
Thank you. Thank you for having me. Thank you.
All right, guys. And I'm going to transition to the closing of our session. So thank you so much for sticking with us and for those questions. So right now it's time to check out, I guess you would say. Ronnie, do you mind putting out the link in the chat box, please? You can also scan, as always, this QR code to complete your post test so you can work on your certificate and close out this session. Looking forward into the future.